There are about 7,000 diseases, only 500 treatments available. Patients with rare diseases frequently have no approved treatments. This forces these patients to find off-label usage for medication to treat their condition. If the FDA has rules limiting information to doctors and patients, this could harm a patient's health. And I know this was touched on earlier. Our health system should be patient-centered type of care, in my opinion. Given that, how can we ensure that patients and their physicians have access to information, whether it be on-label or off-label uses, so that they can determine the best course for treatment?
Thank you, Congressman. I think the best way to do that is to ask the FDA or direct the FDA by legislation or statute or regulation changes to allow that communication to go forward. Right now, that communication is badly stifled, and much of the information that pharmaceutical manufacturers and innovators have is hidden from our view. Rheumatology treats many diseases that have no defined treatment. There's no medication that's defined to treat Sjogren's syndrome. There's no defined treatment, no medication specifically defined to treat chondrocalcinosis. There's some of these unusual diseases that aren't really rare. We see a lot of people with that, but we have no defined mechanism or medicine that's approved to use in these diseases. But things like Sjogren's syndrome, I'm certain that the pharmaceutical company that's manufactured some of the medications available today have had crossovers with patients who have Sjogren's syndrome, and they have data on how those patients' Sjogren's symptoms improved or worsened, which is also important to know. Did a particular medication make that particular subset of symptoms worse? Those things are important for us to know, but those things may not be readily available to us, and those would be very helpful to have.
Thank you. Would it improve the standard of care to have these indications on the label, such as ensuring correct dosage and access through insurance reimbursement? And should we incentivize sponsors to do the additional studies to get these off-label usage on label?
I think incentivization to do some of these studies on these small diseases would be very, very helpful. It took 15 years to define that dermatomyositis was treatable with a medication that's been on the market for 20 years. It took that long to get a large enough sample size to prove that the medication really worked. And dermatomyositis is a devastating inflammatory disease of muscle that destroys muscle tissue and skin. So incentivizing those types of things would go a long way. Now, National Institutes of Health already does that, as they were the ones who sponsored the actual study on dermatomyositis. But incentivizing manufacturers to go forward with some of these smaller diseases would be very helpful. Yes.
Very good. Thank you very much. Mr. Musallam, you mentioned that it was 4 years after the EU approved, before the FDA approved the Sapien Valve. Is the U.S. typically behind the EU for device approval? Why, and how can we accelerate the process?
Yes, it was 4 years difference. I would say generally in medical devices and medical technology, manufacturers would introduce their products first in Europe. The burden of proof to be able to introduce in Europe is much lower than the burden of proof required by the FDA. There's a level of safety that needs to be established in Europe, but a much lower level of efficaciousness that's required before it moves to the marketplace, and it's left to the judgment of physicians and patients and whether it should be used. The FDA requires a much higher level of science to bring it to the United States.
How can we accelerate the process here in the United States?
Well, there's several ideas, and a number of them have actually been mentioned by Jeff Shuren, who's responsible for CDRH, including trying to think more carefully and take a risk-benefit analysis and think carefully about what might be collected in a pre-market setting versus a post-market setting. If you were to have, in the cases where patients really need the benefit, if you were to have a pre-market setting that wasn't so onerous, but rather have more extensive study in the post-market setting, What you could do then is potentially speed these cures to people that really need it when in the judgment of FDA, it was the right thing to do. And at the same time, make sure that you're collecting the evidence so that therapies that are winners get supported and losers get stopped.
Well, thank you very much. Appreciate that. And I yield back, Mr. Chairman.